Good evening once. Right. Good evening once again. My name is Dr. Linda Kemunto. I'm the treasurer for the Kenya Medical Association. I'll be your moderator for this session. I would like to welcome all of you to this webinar series. As you saw in the poster, we'll be discussing universal health coverage and the new health acts that were assented by the president over a month ago. We, as the Kenya Medical Association, have partnered with the Kenyatta National Hospital and the University of Nairobi webinar platform, together with associations, the Kenya Dental Association, the National Nurses Association of Kenya, the Pharmaceutical Society of Kenya, the Kenya Clinical Officers Association. We also have our partners and sponsors, the USAID, PSI Kenya, Kenya Healthcare Federation, and Halcyon Consulting. We would like to also say that we are in collaboration with many more partners who are in the healthcare space, and we would hope that with further engagements, you can collaborate and improve or give benefit to our members. So a little bit about the Kenya Medical Association. It was founded slightly over 55 years ago with the mission of taking care of the welfare or looking after the welfare of the doctors and improving the, ensuring that Kenyans access quality healthcare in the country. And I believe we share the same mission of delivering quality healthcare with all the other associations and our partners and the attendees present. This webinar series is in 5 parts. Today will be the introduction on UHC and the social health insurance framework. Then the other sessions now will delve into the 4 main acts, which are the Social Health Insurance Act, the Digital Health Act, the Primary Healthcare Bill, and the Facility Improvement Bill. So we'll have a day for each. And should there be a reason to extend beyond the original 5, we will do that. The aim of this series is to educate healthcare professionals on these new health acts, because these are essentially health reforms that are going to change the landscape of how we deliver healthcare in this country. Not only deliver healthcare because we are the providers of healthcare services, we are also Kenyans. And by that, we are bound to also be patients at some point. And also as employees and employers in the healthcare space, these are acts that will impact on how we deliver healthcare. And that's also how we stand in the global space, because we belong to a global network. And we all know from the WHO that universal healthcare coverage is a global goal. And all nations are on this journey to universal health coverage. Today's panelist is mainly experts in health financing and the drafters and custodians of the new bill, the people who've been working behind the scenes to deliver this the 4 acts, basically. We'll have a candid discussion, and we want to know from the experts why there was a need to have new bills and acts in place, why we needed new regulations, and how these new regulations will impact us in our day-to-day operations. CPD points will be provided to the healthcare professionals that are accredited from their respective organizations. The emailing list has the details. We have a question Q&A box. Kindly enter your questions there. Keep the questions short and simple for us to be able to relay them to the panelists. And we'll also be having a look as we go. We would also appreciate feedback. The chat can be used for other discussions or comments, but the Q&A, we can limit it to just questions for the panelists to answer. Again, thank you and welcome to this webinar. So we are going to just start straight ahead from introducing the panelists, which you can see from the screen. We are going to have Dr. Thuranira Kaugiria, who's the technical lead health executive in the Office of the President. We have Dr. Elizabeth Wangia, who's the Director Health Financing at the State Department of Medical Services, Ministry of Health. We have Dr. Abdi Mohamed, who's the chair of the Kenya Association of Private Hospitals. And we have Dr. Mulongo Mike, who is a health financing specialist. And we will, the speakers can introduce themselves further if there's things they need to tell us about themselves, but we are going to just start right ahead with the discussion. And I would like to direct this question to Mulongo to start us off. Maybe from the start, we need to understand what is this universal health coverage? What does it entail? What are the basic tenets of universal health coverage? We know, when the president speaks or politicians, when they talk to us about universal health coverage, it's always about healthcare being free. And the question we need to ask ourselves is healthcare truly free? We have in this country, we have free primary education, free maternity services, and now we are on a journey to universal health coverage. What does this universal health coverage mean to us? Over to you, Dr. Mulongo.
Thank you very much, KMA and the conveners of the meeting today. And thank you for the question. It's a pleasure to be part of this conversation. You ask about what universal health coverage is. And I mean, from the theoretical side, and the aspiration of the same is that really universal health coverage should be really all persons, all people should be able to access health. And it's just a full range of quality health services that they need, when they need it, where they need it, and without suffering financial hardship as they seek for that care. So that's the general desire or aspiration of universal health coverage. It's summarized as leaving no one behind for purposes of advocacy, but suffice to note that it's really just ensuring that all persons access quality health care and quality health when they need it, where they need it, without suffering any financial hardship. Now, the concept of universality in itself then becomes something that is debatable, because that then becomes contextual. And it will vary based on the nature of a country, the disease burden, the resources available. But the general aspiration is that no one within any context should be left behind. So that suffice to note, that should be the general aspiration of universal health coverage. The other question that I think needed some reflection is, so why is it a priority both globally and locally? First of all, I think it goes without saying that health in itself is a right. As a right, it is recognized both globally, and I think we as a country signatories to international conventions that actually elevate health as a fundamental right. And for instance, the International Covenant on Economic and Social and Cultural Rights, that all the state parties should guarantee that everyone should have or should enjoy the highest attainable standard of health, mental and physical health. And that also is replicated in our constitution locally, I think Article 43, that again guarantees that every person has a right to the highest attainable standard of health. To that, then, it becomes an obligation of the state to ensure that all state parties and all state organs not only observe, but also respect, protect, and promote this particular right. That's the first thing. Health is a right, and that's why it is a global priority. Number two, it is an important anchor to sustainable development. And how so? It's essentially, you will not achieve global development, regional development, or even nationwide development without individual health, because It is the individuals that drive the economy. It is the individuals that drive productivity at country level, at regional level, and at global level. So to that extent, if you want to guarantee sustainable development at both local and global level, then it is important that health becomes an anchor and a priority in that conversation. I will pause there because I know there will be a lot that perhaps I need to unpack around the principles of UHC, but I'll allow Linda, in case there's any comment or question before I address the tenets of UHC. Over and thanks.
All right, thank you, Dr. Mulongo, for highlighting what universal health coverage means and the principles that, it's not just saying it's free healthcare, but just a solidarity movement where everyone can access healthcare. I would like to move to Dr. Wangia, who works at the Ministry of Health. And as we all know that UHC is a global goal, and so is it a national goal. And over the years, we've canvassed over what UHC should look like. We have tried in the previous regime. In fact, before the previous regime, I think a few years back during the Kibaki regime, there was an attempt to have a social, to convert NHIF to a national social insurer. And perhaps that was maybe in the 2000s, the earliest attempt at UHC, though it wasn't called universal health coverage. And in the last regime under President Uhuru, there was an attempt to launch UHC. We had pilot projects, and this dream has been carried on with the current regime. So from the Ministry of Health and also from your experience globally and locally, what is your opinion on how UHC should look like from the global perspective? What lessons have we learned from other countries and what we've tried before? And perhaps what are the best practices in achieving universal health coverage in your opinion? Over to you, Dr. Wangia.
Okay, so thank you so much, Linda, and also to the KMA and KNH team for inviting me to share with you on UHC and also specifically on the social health insurance. I'll start by riding on to what Dr. Mulongo talked about regarding the entire goal, when you look at the goal of UHC. And the goal mainly looks at, provision of access to quality health services. And of course, the second aspect of it is around, financial protection. Basically, what that means, it's putting in place measures or strategies that will ensure that the population don't go into poverty while seeking healthcare. And with that, we know globally a number of countries have really tried and attempted, of course, and let me say even succeeded in the journey towards UHC and of course through a social health insurance model. But one thing I can say is that this is not a destination, it's a journey. I would give an example, like it took Germany around 127 years to say that they have fully gotten into social health insurance and of course basically universal health coverage. Quite a number of countries are in the 70s, above 100 years, and there have been several attempts looking at whether, targeting interventions that target the poor, interventions that look at the employed, and all that. There have been quite a number of mixed models that have been used even by several countries. But one thing that I can say is that anytime you're thinking of attainment of universal health coverage, there are quite a number of things that probably you would really want to put into consideration. And some of them include looking at the level of income and the rate of economic growth, because this is what will determine basically, the chances of even the citizens either purchasing health or, you know, it will look at the chances of the citizens to purchase their purchasing power. So as much as you may want to put in measures, if say your income per capita is low, then your general purchasing power is low. So with that, you may have to look at what approach would you use in such a case. Then sometimes you may also want to look at the structure of the economy. For instance, our country is largely informal sector. 80% of the citizens in this country are informally employed. So you may not just pick a strategy, say from Germany, where close to 100% are in the formal sector, and bring it to Kenya, where a large proportion are in the informal sector. So some of those things that are considerations to be put in place when thinking of either social health insurance, or even when you're thinking of strategies towards attainment of universal health coverage. Then you may even want to look at the distribution of the population, whether you have a largely urban population, because as we know, in urban areas, say the communication channels are advanced, infrastructure is there are many people per, you know, the population density is high, and therefore if you are to put in an intervention, it becomes quite easier compared to probably if population is largely rural, where the, you know, reaching each and every person becomes a challenge. Then the other thing we may want to look and consider is the level of solidarity. What is the general nature of the people in a community or in a country? Because we may find, I would say, like Kenya, I think we have good solidarity. As you can see, when you're called for harambes, we quickly come together and want to support another person. So with that becomes also a plus when it comes to looking in areas around social health insurance. Then in terms of stewardship, we really need, for attainment of universal health coverage, you need a strong governance and strong stewardship that will, that will manage to engage the citizens and even convince them of the initiatives that need to be put in place. And with that, I believe as Kenya, we have really also put a lot, of initiatives towards attainment of universal health coverage. We know as it is right now, under fives are, I would say, treated for free. We have the fact that vaccinations, HIV drugs, TB are free to the people. It doesn't mean they are free, but to the citizens, we have ensured that some of those strategic interventions are free, therefore affordable, or have no cost actually to the population. We have seen in interventions like Linda Mama that ensures that this select group of people are able to attain, seek services, get services, including the poor. As it is right now, we cover also the poor and the people with severe disability and the orphans and vulnerable children. So all these are models that have been put in place. We know that even within primary level facilities, which is the dispensaries and health centers, the services are, I would say, free, so to speak. So some of these initiatives are what the governments over the years have put in place. So what we do is that you always, since it's a journey, there's always an incremental, interventions need to be actually incremental, and of course, learning from previous approaches to attainment of UHC. Over to you, Linda. All
right. Thank you so much for bringing out the concepts and highlighting that indeed universal health coverage is a journey, not a destination, and that in as much as we are on this journey to UHC, there are certain aspects in our healthcare system that we ought to appreciate that have reduced financial burden on Kenyans, like the ones you've just mentioned, the Linda Mamas and the Afya Boras of this nation. I would like to move on to Dr. Thuranira for the more political questions, because now you speak for the office of the president, or you can correct me. But we would like to understand from your perspective, why was it necessary for us to have new policies? Why were they key? And also highlight perhaps what is this Kenya Kwanza, the plan of Kenya Kwanza, rather the Kenya Kwanza manifesto, because when we look at it, there are certain things you have highlighted, or the Kenya Kwanza manifesto highlighted in terms of NHIF reforms. And now we are seeing a shift from NHIF to a social health authority. Perhaps why is it necessary now to move from proposed reforms to a completely new body? And also from the manifesto, there was an attempt to sort of identify a problem whereby the out-of-pocket expenditure was about 150 billion. And the idea for these reforms
Did we lose you?
Yeah, I think we've lost her.
Dr. Thuranira, I think you were able to capture a bit of the question. So
Yes,
maybe
yes, I have.
allow you to take the floor.
Okay, thank you very much, and thank you for the opportunity. I'm happy to be back. I remember when we started this UONKNH webinar platform when COVID struck. So my name is Dr. Thuranira. I'm happy to be here as a panelist, seeing my colleagues, seeing people we worked with, seeing people we have worked in journey. So I wanted to answer that question with a small presentation, and I would request, sorry, I'm traveling, so I'm not able to project. So if anyone can project my slides, Brenda, if you have them, kindly project the slides. Then I quickly rush over them. There are like 10 slides. So while at it is the Kenya Kwanza plan for health started being drafted in December of 2021. And the team was formed up in February, and I've got the opportunity to work for it. We did the plan and we came up with a manifesto. What you see out there is just a brief summary of the long document that we developed. So I work in the Executive Office of the President as one of the presidential advisors. I'm the technical lead health. I work with Dr. Moy. Dr. Moy is a health economist, lecturer in the University of Nairobi, and he's here and listening in. So next slide. So in our plan of delivering universal health coverage, we picked 4 pillars of healthcare, and the 4 pillars are summarized in the next slide. Digitization, human resources for health, health financing, and commodity security. Next. And as such, we decided the plan is to deliver an essential benefits package that has both, with focus on primary healthcare, which we call Afya Nyumbani, started as Afya Bora Mashinani. Now it's Afya Nyumbani. It is based on a community level service and facility-based service. The next one is a secondary and tertiary. Sorry, somebody is trying to that hospitals. You can hear me? Hello? Can you hear me?
Yes, we can hear you now.
Thank you. Then we decided to add on ambulatory services, that is ambulance evacuation and emergency services, and then last expense. Next slide. The shift is to do more of primary healthcare, not neglecting curative services, but now to focus more on a primary healthcare-based approach, which what I'm showing here is a financing model. The primary healthcare, which shall be provided at a community level, a level 2 and a level 3 shall be tax funded. So we are used to saying that we want a tax funded healthcare system. So we have been able to convince the political class and the decision makers that we need a tax funded primary healthcare. Then the level 4, level 5, level 6 shall be funded under a social health insurance, what you commonly call NHIF, but a social health insurance. Upon depleting your cover, you can use a chronic illness and critical illness fund. As you know, all know, Article 43(2) of the Kenyan Constitution provides for the right of every Kenyan should get emergency services. And as such, that article of the Constitution has never been operationalized. 13 years after that is when now we come and create the emergency fund, anchor it in law. Next slide. So the primary care approach next, we are focusing more on a primary care, it's a primary care approach, which will be preventive, promotive, comprehensive, integrated, based on primary care networks, where a group of several facilities, level 2s and level 3s, form what you call spokes that converge in a hub, which is a level 4. And you have heard a lot of talk about primary care networks, and there shall be sustainable financing for these, factoring in the different models of vertical programs that have been there. So the next slide is just to give a summary of what a primary care network is. And so community level provision of service shall be provided by community health promoters. These are the commonly known community health workers that you are used to. They were there. They're offering services voluntarily. That's what they were called, either community health promoters, or volunteers or workers. But this government made a commitment in the manifesto to recognize them, to give them a stipend and to equip them. And as you have seen, how is 100,000 arrived at? We assume that Kenya, we are 50 million. Being 50 million, an average family size is 4.5, between 4 and 5. If you use 4, that's 12.5 households. If you use 5, those are 10 million households. And if one community health promoter covers 100 households, then it's 100,000 community health promoters. Of course, there are those hard to reach population. There are people in diaspora. We have people in urban centers, especially where Linda lives, where we cannot reach her, and several other people here. Next slide, Ken. So the next slide just shows the formation of a primary care network and how facilities are organized. Several level 2s, level 3 facilities based on a catchment area converge at a hub, which is a level 4 facility, taking care of a population of 150,000. And 150,000, now you create a primary care network. This seems to be more at a sub-county level. And once you bring in both private facilities, government facilities, and faith-based facilities, they all provide care. And as such, we are going to map them into a primary care network. Next. After that is how the primary care network shall work and how it is formed. There shall be multidisciplinary teams, but more importantly is a governance structure of primary care facility networks, where you shall have representatives from the MDT team, community. You need community involvement, so you need community to be there to map how services shall be procured and services shall be. The decision of services that shall be bought on based on the disease burden and the needs of the community shall have a representative from government, that is the sub-county health management team, representatives from faith-based organizations, representatives from private facilities, but more importantly, representatives of the donors, because they tend to do a lot of activities there. We avoid verticalized kind of programs, but we go to integrated kind of programs. Next. So after that, we came up with a social health insurance, and there's a team already developing the essential benefits package. It shall encompass most of these things, but of note that things that had never been factored in, the issue of mental health, drug rehabilitation, has been given a lot of limelight in it. And you know, our deputy president is a champion of that. Number 2 is the issue of screening and annual checkups for Kenyans. So in part of the package, you shall have that. Then issues of eye, oral, inpatient emergency services also shall be, and basically oncology services. Most of you might know that professional associations are involved in the development of this package, and you've been called to Naivasha. Our able boss here, Dr. Wangia, has been overseeing that process, and most of you are involved in it. I think I have 2 more slides after that. Next. So digital superhighway is, we want to digitize healthcare for one, telemedicine, two, portability of data, and basically visibility, so that you don't wake up in the morning, you go to this facility, when you go to the other facility, your records cannot be recalled. And as such, if you know, part of the things that we launched during the UHC week at Kericho is a fully digitized primary care network in Bureti sub-county. It's called a smart PCN. If you might want to know more details about it, you might ask. It's totally paperless, end-to-end, from radiology, all points of service. And you can see the data moving from whichever facility to the next facility. So the issues of a patient comes in, you ask them what medicine they take, they say it's some bread, small brown tablet, trying to recall what it is, would be a thing of the end of the past. Now, next. The other thing is human resources for health. I know this has been a hot topic. Part of the things that Kenya Kwanza promised is employment of healthcare workers to the tune of 20,000. It's a talk that is ongoing. It's at an advanced stage. But more importantly, there has been a clamor for a health services commission. And I'll tell you, having worked in the union and now working on this other side, it's a totally very political issue. And it's a hot topic that whenever it is brought, you know, who supports it and who doesn't support it. I won't mention that for now. So essentially what the government chose is to empower what we call the Kenya Health Human Resources Advisory Council. It has representation from the Attorney General, the Public Service Commission, the county government, the national government, Ministry of Education, and they have been involved in a lot of work. And this culminated in the signing of what we call the Kericho Declaration. Some of you might have seen the contents of that document. I think the last slide is to talk about the legislative framework. Now, with all these big ideas that you have, there are big ideas on paper, and the mistakes that you've been doing previously in the launches of whatever universal health coverage programs you've been doing, we have never anchored them in the law. And as such, we decided to anchor all these things in the law so that, notwithstanding who shall be the president of the Republic of Kenya in future, the things are anchored in law. So first, we start with the Primary Healthcare Act of 2023. Kindly let's stop calling them bills. We moved past that. The moment the president assented them into law, they became acts of parliament. So Primary Healthcare Act that provides for reorganization of the healthcare from community to level 3 and clearly stipulates the sources of money, hence tax-funded, publicly funded primary healthcare. It is not contributory. Number 2 is a Social Health Insurance Act that has brought a lot of discussion. And this one now reorganizes how the primary healthcare fund shall be and how the emergency, chronic, and critical illness fund shall be. The next one is the Digital Health Act that provides for issues of data governance. As you know, the Health Act provides for issues of data, but more importantly, the Data Protection Act provides for that, but it's not clearly stipulated on the issues of health. So now this one is specific as to how health data shall be handled. The last one is the most popular, less controversial Facility Improvement Financing Act, whereby all monies according for health shall remain at health, do functions of health shall remain in a health facility. So all the county collections that come from services paid for by insurance or cash payers, and more importantly, money is appropriated for health from the county assembly, the national assembly, donor money, and also monies for public health, including inspection of buildings and the inspection of abattoirs and slaughterhouses. All that money is health money and shall be ring-fenced in health. That money shall remain within the facility. The facility shall have the final say in how the utilization of that money shall be. What is pending is that we are drafting the Kenya Quality of Care bill. Now, this is called a bill. The drafting process is just about to start, whereby we need to have a quality of care authority. Now, based on what I've presented, good people, we have political goodwill in this government. Everybody is talking about health. Probably some things we are getting right. Probably some things we are not getting right. I'll assure you that this is one of the governments I have interacted, probably worked under the previous regime. I have worked in this regime. Probably we have more political goodwill than we had previously. And this is the time to take advantage of what we're getting. I think probably my last remark before I fall off, because my network is really bad and I'm moving, is that all I'm encouraging you people is that let's interact with these bills. Let's read these acts of parliament. Let's read everything that is out there. Let's not criticize for the sake of criticizing. I tend to see us colleagues posting things out of ignorance, and I feel very bad. It is good to read. Lastly, we know there's a court injunction. We acknowledge that there's a court injunction against the implementation of the Social Health Insurance Act. Yes, the lawyers will do their business. There's no good thing that comes without a fight, so we are prepared for it. The lawyers shall do their work. We shall move on. But more importantly, that the social health insurance regulations have been drafted, they have been advertised, they are out there for public participation. The process of public participation is normally like this. The bills are advertised for a minimum of 2 weeks. It's you to take them, read them, understand them, and write your comments. That's number one. Number two, there shall be forums of engagements, whether on TV, on radio, in hotels where we like saying eating mandazis and sausages. And we shall engage, and all your comments shall be factored in. It is good you criticize. It is work that has been done by colleagues, not only doctors, clinical officers, nurses, but all cadres of health. The technical working groups are people among us. People have been drafting these things, are brains within us. They are not foreigners, they are not Tanzanians, they are not Ugandans, they are Kenyans. So as you criticize your work, our work, just know it's work that has been generated by part of you and your colleagues. So participate in public participation, and let's do that. Thank you so much, Linda. I think I've taken so much time, but I just thought I should share that. Thank you. And that's my last slide. Thank you.
All right. Thank you, Dr. Thuranira, for highlighting the roadmap to the Health Acts as per the Kenya Kwanza manifesto and what we are doing. And the last ending is, you know, a rally to call us to solidarity, perhaps maybe a bit harsh, but I think you can look through the chat box, all the panelists, and see the questions people have. Just a follow-up from some of the questions posted, because we might lose Thuranira along the way. So I think I would like him to respond to some of the questions before we proceed. There's someone who asked about what mental health and rehabilitation frameworks are there in this current act. I think that has been answered extensively. Another comment from one of the participants, they're saying that the UHC and the journey to UHC is actually a good thing. However, the strategy seems a bit incoherent. So I don't know if it's incoherent because it's not being, the information is not being cascaded well. Dr. Thuranira has also encouraged us to read, so I don't know where it stands, but that's just feedback. There are comments on immunization, and there's a looming pullout of the Gavi who have been supporting immunization, which is a basic primary healthcare service. I think this question maybe Dr. Thuranira Rwangia can answer. Are there strategies in this current PHC Act to ensure that even as our global partners pull out on some of these essential services, that we have money ready to procure vaccines and have our population vaccinated? And another question that is asked, this one is to Thuranira perhaps, what is meant by tax funded? You know, every time Kenyans hear tax funded, now we are about to, you know, want to leave the country because we're already suffering a lot of taxes and levies. So there's a question there to clarify, what does tax funded mean? Are we going to be taxed more, or there's already money there, or where does the money come from when you mention tax funded primary healthcare, critical care, illness? And then the last question to Thuranira is the idea that this social health insurance is pulling or having a solidarity where we are pulling the vulnerable populations and ensuring they access healthcare. But then it may seem that the people carrying the biggest burden are people with on a pay slip because they are the easiest target in terms of generating resources. And what do you have to say about that? In as much as you're talking about equity and pulling everyone up, the people perhaps at the top may want to also have some form of equity also in their benefits. And linked to that is the question of the civil servants cover, where people have this act, the SHI Act has specifically said there will be no fragmented pools or enhanced schemes. I think I leave it at that. Thuranira, you can give your comments. Then Dr. Wangia, you can answer the Gavi question.
Linda, I would really feel bad if Abdi doesn't talk before me. I still have, I think Abdi can say his comments first, then I answer the few questions I can. He's a guy I really respect.
No problem, no problem. In that case, then we can proceed to the other questions, but keep the questions in mind. So as we move along, it's the first time you're seeing the entry of private sector into this social health insurance, in our government-funded insurance, especially in the from all the way from PHC to the level 4-5. We're seeing that private sector will have a stake in this social health insurance and also in the delivery of primary health care. So Dr. Abdi, feel free to comment on the previous questions, but the direct question I have for you is, how do you think public-private partnerships in this social health insurance will enrich the process? And the question on perhaps some of the participants is, how or why should private facilities be included as providers in the social health insurance? For those who've read, there will be no discrimination between private and public facilities. So as the representative from the private sector, we would like to hear from your perspective why this entry is important, and is it a good thing or a bad thing? Over to you, Dr. Abdi.
Thank you, Linda, and thank you, Thuranira. Actually, I'm willing to just listen. I really don't have to speak. But if I'm supposed to answer on some of the things or the questions that you have even asked to Thuranira. So when you want to deliver UHC, there are two main mechanisms that you can use to finance it. One is the social health part, where people contribute insurance based on their income, their ability to pay, which is also equitable. But there is also a second part where you can use general tax. In terms of using tax is the general budget, whatever you allocate, the same way you allocate money to the Ministry of Health or Ministry of Defense or Agriculture, is the same way you will allocate money for UHC. But in some other countries, they go a little bit further and they do what's called earmarking. So they have certain taxes specifically for UHC. So they say if it's beer, sin tax or excise on beer is 2%, that 2% collected will always go to the health sector for UHC. So that's also one area, one way of financing. In this Social Health Insurance Act, what the government has tried to do is to use a mixed model so that you don't burden the general population specifically to remove for health out of through social health insurance, but also to assign some part of tax from the general collection for UHC. So that way, the burden of financing the benefit package is not left alone to the population. And that helps also in increasing the benefit that you would like to give to the public. The reality is that there's no amount of money that's enough for you to provide health 100% to the way people would like it. There's always certain things that you will have to forego. There are certain things that you have to prioritize. So basically, there is no enough resources to say we are going to give 100%, because you need to keep in mind that you have to continue training the human resource required to deliver. You need the infrastructure required in terms of facilities. You need the equipment. You need the medication. So there is no enough amount of money that you can say this is the right amount for you to deliver. And also, you are not even guaranteed also that whatever amount that you are putting in is enough. The outcomes that you are getting gives you is equivalent or cost benefit wise is appropriate. When it comes to private sector, I think it's Obama who said once when he was talking about women in leadership and having in higher positions. And I think it's when he came to Kenya. So when you remove half of the population and you say it's only men who can hold these positions, what basically you are saying, you want to play a football match with, instead of 11 players, with 5.5 players. What do I mean? The private sector, both faith-based profit and non-profit making, contribute almost to 50% of care that's given in this country. So there's no way you can say we want to push out the private sector and deliver services. You will fail. And it seems this government has learned from the previous government. The reason why the 4 pilot counties, and I've seen that question was being asked, what happened in those 4 pilot counties that were done? The 4 pilot counties failed because government at that time tried to provide UHC in public facilities only. And what they have done is they did what's called input financing. So they were providing drugs, reagents to facilities, to public facilities. What happened was there was an upsurge, an uptake of those services. And the next thing that happened was counties withdrew their own budget. So you overwhelm your facilities, then service delivery becomes poor, and then the public now get dejected and they move away. The other issue that came up was because you are doing input financing, if you take one example, one county, it has around 100 to 150 to 200 facilities. In that 150 to 200 facilities, you will find in each of the laboratories in those facilities, it has 2 or 3 different glucometers. So if you are doing input financing, you can imagine the nightmare of trying to buy reagents, glucometer, the strips for 500 glucometers in those facilities, or 1,000 glucometers. You have no scale of negotiating. You have to look for each of the different glucometer strips suppliers to give you that kind of, to buy. So now imagine going step by step, hemogram machine, move next, move next, move next. Then you realize that is also impossible. The other thing that happened during that time is the people who used to pay for NHIF now stopped paying. So there was a drop in contribution to the social health insurance, which also means the only people who dropped are the informal because theirs was voluntary while the formal guys were mandatory. So that also meant less money for NHIF from those 4 counties. So with this current system, I wouldn't say it's perfect, but it's the best so far of what we can think of, that it will be able to address most of those challenges, most of those failings, by pushing the idea of output financing, so that you deliver services, and that's now when you are paid, whether you are public, private, mission, so that the choice is with the patient, and the patient is every Kenyan, so that they have that ability and the freedom to say, I would like to go to this facility and this is what I want. These are the kind of services that I want. And that is the reason why private has been put on board and be able in terms of to deliver the services. Because when you remove the private, what basically you have done is you have removed access. Yes, you have provided the financing, but now you have limited the access. So it's a sort of a zero-sum game. You haven't helped in any way, because when there's no access, you will keep your money, and the patient is not benefiting in any way. I hope I have tried to answer the questions as much as possible.
Yeah, and I see why Dr. Turandira wanted you to speak first. So Dr. Wangia, there's a question for you, but just hold it there. I think just for continuity of this discussion, the big question then becomes, what is the difference between NHIF and the social health insurance in this, in terms of access to services? What services can be accessed and where? We've tried to also show that, or Dr. Turandira has also shared that people can access services from primary healthcare, but perhaps we can still highlight further where people can seek services and what are the expected benefits. Will it be better than the current NHIF, this social health insurance, and the other funds in the Social Health Insurance Act? Then how much resources are we expected to pull? Will these resources be enough to manage our healthcare needs, or we'll get to a point where we've pulled resources, the resources are still not enough to cater for the health of the population? And also, what are the differences in processes? Perhaps like, I saw a question on sort of registration. So maybe take us through the process of this new social health insurance fund and how different it is in terms of processes, all the way from registration to the claims process. Just giving an highlight, because we will delve further into this discussion on what the differences are in our next session on the actual act. Dr. Wangia, I think you can take that and just highlight the key differences in terms of NHIF and the social health insurance.
So thank you very much. I've put my video on. I saw a comment that the panelists are in the dark. So anyway, thank you for that question. I know we have another session, the part 2 of this webinar will really dig deeper into the social health insurance, but just allow me to give you some differences. First of all, one key thing is that there's been separation of key functions. Number one function is claims management. Within NHIF, this was one of the things that were being done, but when you look at the Social Health Insurance Fund, the function of claims management is separate. The development of the benefit package is also, will also be, it's actually separate. This one will be done by the Ministry of Health, of course, in consultation with the Social Health Authority. Looking at who exactly contributes. I know within NHIF, the contributions were actually mandatory, but there were no initiatives that were clear initiatives to make these contributions mandatory. And I know it's been, there's been a lot of, you know, for lack of a better word, hulabaloo around people not being able to access key government services. There's one I saw just yesterday on marriage certificates and, you know, driver's license. And yes, so we are saying that we will not only say that it's mandatory, but we'll put in measures to ensure that that it's actually mandatory. The other thing that is key within the Social Health Authority is around the fact that we'll be able to contract both providers and health facilities. In terms of other functions that are separate is things to do with accreditation. So the only thing that SHA will do will be to empanel facilities and contract them, but then the accreditation will be done by an accrediting body. Thuranira talked of the Quality of Care Authority that will come into place once we have drafted the bill. But for now, the body that is in charge of ensuring quality of facilities will continue doing its work. There is one thing that is really emphasized within the Act, which is digitization of the processes. We have said that the processes will be digitized as much as possible, right from registration up to claims management and payment, just to ensure minimal user interface, and of course trying to curb system generated fraud. The other thing that is quite key is in terms of clearly outlining the explicitness of the benefit package. Many times people could ask, and I remember it was more of an FAQ around what exactly am I entitled to under NHIF. People could post, you could see posts or questions around, is this covered or not? But in this process, we are saying we have really outlined explicitly how we will, the process that, in terms of the development of the benefit package, and actually within the regulations, the benefit package and the tariffs will be posted. So in terms of, reducing, in terms of increasing transparency, both the benefits and the tariffs, I would say like the prices will be posted within the regulations. Then the other thing is around what Thuranira talked about in terms of looking at the individual. If I want to give an individual a Kenyan quality health services, then it won't really matter from where I buy those services from. And that's where the private sector comes in play, where we'll be contracting even at primary care level, both the private and the public facilities, so long as the Kenyan is able to get quality services. And finally, in terms of reimbursement, I've mentioned about the benefit package, and the benefit package reimbursement will be based on what we call a tariff. So if we say that it costs this amount to, to manage, say, what, maybe let me say delivery, to conduct a delivery, then that delivery, a normal delivery, will have a tariff. And irrespective of where an individual goes to seek service, that tariff will be applied. So if you go to Nairobi Hospital, we'll tell you as social health insurance, our tariff for delivery is 10,000, for instance. I've not said it's 10,000. And it will take away that, that notion that was there before, that yes, people within the informal sector, the ones who contribute more, yet when they go to a health facility, they're only paid bed only. This time we are not doing bed only. We are saying every condition, every intervention will be based on a tariff, and that tariff is the one that will reimburse on. Of course, there is what we call provider payment mechanism. So we'll also agree together with the key stakeholders on how these provider mechanisms will be. And that one is more of, are we doing fee for service, like a fixed fee for service? Are we doing case-based? Do we do capitation? So all that will be determined, and we will pay based on that tariff, irrespective of the, irrespective of this, where the service is offered. So I think those are some of the key differences. Then in terms of the resources, so we did some projections, and we did together with some economists, and of course, even together with the Kenya and National Bureau of Statistics, And we looked at we looked at consumption data, for the entire country based on surveys that have been done. Surveys that have been done at household level. We have what you call the country integrated budget survey. So that one actually tells us what is the consumption habit of the people. And consumption is not equal to your salary. You may be earning less, but you consume more because probably you're earning a certain amount, but you have other sources of income from other places. So consumption data is even a better indicator of people's, ability to pay. So when we looked at the consumption data in general, and we banded the consumption, in percentiles, we were able to, using a figure of around that 2.75 that is captured within the regulations, we were able to get a yield of around 148 billion. And this is looking at the formal sector, the people who are employed, looking at if they contribute for the formal sector, we basically looked at the salary. For the informal sector, we mainly considered the consumption, the consumption data. And based on that, we saw that if we are able to reach the informal sector, then we should be able to raise 148 billion. For the primary healthcare fund, and that is only for the social health insurance. Remember, the social health insurance is the one that is contributory, and that's why we are looking at the collections. So for the primary healthcare fund, we have been working with a figure of 77 billion, and for the emergency, chronic, and critical illness fund, we have been working at a figure of around 49 billion. And this is based on data that we had, some actuarial data that we had done earlier in the year that showed us that primary healthcare services are worth that amount. So with this 148 billion, what do? We look at the benefit package. We see how the various things that people want. First of all, we want to maintain the services that NHIF was offering, then also consider additional services based on, the priorities of key stakeholders and the priorities of the population. So looking at that, then we need to be realistic and say, with our 148 billion, we can only afford 1, 2, 3 services. So that is some work that is ongoing. We are in consultation with quite a number of, specialists, just giving inputs on, what they feel is a priority or what they know is a priority, because these are subject matter experts. And based on that, we'll be able to really see what are the key interventions that we can bring into the package and what can we put pending. And the good thing is that even within the regulations, which are now out in public, and I encourage everyone to read, we have clearly said that we will be reviewing the package every 2 years. And before the 2 years elapse, twice a year, we'll be calling out to key stakeholders to submit their propositions. This week has been a busy week. I've been receiving quite a number of calls from different people telling me, can we put this into the package? Everyone wants something to be within the package. And therefore, moving forward, that's why we're saying we'll have a systematic way of receiving such requests, subjecting them to some scientific criteria, and then looking at our envelope, because we also know that we have a limited envelope. Looking at the envelope and seeing how it can fit. So basically, that's the work that has also been ongoing on the side of the social health insurance fund.
Can I add a statement?
Proceed.
So I want to tell you a story, and the story I want to give is about NHIF. So NHIF comes to your house, convinces you to be a member, so it registers you. Then it collects your contribution to give them money. And it goes and inspects facilities and panels facility, contracts facilities. Then it tells you can only seek healthcare in this facility. You remember you have to choose a facility. It tells you to choose a facility here and choose this one. This is where you are capitated at. This is where you can only get cover. Then when you go to that facility, pre-authorization has to be that they pre-authorize you. So you get your service. After you've gotten your service, the hospital sends the claim. They manage that claim. They look at it, they decide this one is payable, this one is inflated, this one is not inflated. Now they go on to the next step, they pay. So they're the payers. After they pay, they realize you as a facility, you are the fraudulent one. So they come and inspect your facility, they investigate you, and then they punish you. They audit themselves. They are outside the insurance regulatory authority. Is that the kind of institution you want to go on as you go and deliver universal health coverage? No. What do we need to do? We need to unbundle the functions. And how have we done that? Is by what Liz has explained. That's number one. Number two, it is started as National Health Insurance, Hospital Insurance Fund. Then an amendment came in, it became Health Insurance, but it's more focused more on salaried people, Kenyans who are salaried payroll people. If you look at the data at another meeting, if we organize another meeting, I would wish us to have a discussion on two things. The current data of NHIF, the beneficiaries, the people who have ever been onboarded, the current actual beneficiaries, and you break down who they are and where they are and what they are, you'll find out that the voluntary payers are very few. Now, what are we envisioning? We're envisioning a social health insurance. And a social health insurance has one statement called universality. And universality is universality in contributions, universality in benefits. And universality in contribution is where you remember that 80% of the sector that we have is informal sector. And informal sector includes some of us here who are businessmen doing our own private business, some of us who are farmers, some of us who are doing other things that are outside the normal government framework. From the Abdis of this world, Abdi is the representative of informal sector, to the Mamambogas in the village. And how do you do that? You bring them, everybody on board. Social health insurance has one simple thing: universality in the benefits package, payment contributory mechanism, and the access to healthcare. So you can, the same way a hustler can enter Nairobi Hospital is the same way maybe His Excellency the President or a politician can enter that hospital. How will that be achieved? If I was a hospital owner and majority of the Kenyan citizens have a form of a health insurance cover, I would onboard them and take advantage of economies of scale. The last thing is that I'm sure most of you are in a form of a WhatsApp Harambe somewhere contributing for something, for some medical cover for someone and everything. Look at it at an ambitious project whereby everybody has some form or has a social health insurance, whereby the primary care has been taken care of by the government. When you have to be referred, it is sorted out by the social health insurance. In case of an emergency, it's on 24-hour stabilization. The emergency fund is taking care of that. And if you deplete your cover and it's a chronic illness, part of the money in the chronic illness fund is used. So let's envision that. Thank you.
All right, thank you, Dr. Wangia and Dr. Thuranira. Just a quick follow-up. I think, Dr. Wangia, you mentioned that in this new act, we'll contract both providers and health facilities. Does that mean individual providers, like, for instance, I as Dr. Kemunto, can be contracted as an individual provider to the fund?
Yes, Linda, that is the way to go. Probably initially we may not start with that, but an act is for, it's for posterity. Let me just say that. So at some point in time, we will contract, practitioners. And especially we are thinking of when you're looking at what we call a digital kiosk. And this is mainly things to do with telemedicine. Like, for instance, if you are to offer telemedicine services, then we should be able to also contract you as an individual. But we may not want to start with that. Probably by, say, the second year, as we, as we implement the social health insurance, we may now want to bring in additional, additional services like that. But the Act allows for contracting of not only a health facility, but a healthcare provider. So also
Right.
that when
Okay.
that time comes, we will put in the tariffs for the provider as agreed by, different stakeholders. We'll say for this telemedicine consults, this is what we want to reimburse.
Okay, thank you for
Yeah.
that clarification. And I think that takes me now maybe to Dr. Mulongo. How do you envision that this social health insurance will affect, how will it affect healthcare providers? In the meeting, we have health professionals from doctors, clinical officers, nurses, lab technicians, and we even have, I think, some community health promoters in the meeting. In your opinion, how can healthcare professionals take advantage of this act? And how do you foresee the practice of medicine with this new act? Dr. Mulongo?
Thank you, Linda. I think I have quite a number of comments related to previous issues that have been raised, but I think one that stands out, I think, is with this act and the role of healthcare workers, if I get your questions, and how it may affect them in service delivery. I think it touches on largely, if you're looking at all the acts that have been put in place, there are certain provisions that seek to streamline how care is provided and how payment for that care is provided. If you're looking at the FIF Act, it ensures that resources will remain at the facility level. If you're looking at the Primary Healthcare Act, seeks to clarify the menu of services that the particular caregivers will be offering at their different levels of care, and also makes provision for penalties or consequences for operating beyond your scope. One of the key things that I think is important as well is a reflection on quality of care in terms of safety, timeliness, efficiency, effectiveness, patient-centeredness of the care that will be provided within this new approach. Because I think, as Ranira mentioned, I think their intention is to focus on the primary care, and therefore you have the CHPs, you have the level 2, level 3 providers. I think it is important that then we reflect on how do we ensure and guarantee quality of care at the community level. And that will speak to one regulation that will speak to training particularly. So what is the level of training and competence of the parties that are offering care at the different levels of care? And how do you guarantee quality, and how do you ensure linkage across the levels of care? I think that's one bit that is important. As far as the Social Health Insurance Act is concerned and the impact it may have, I think it is worth reflecting on a number of issues. Number one is the equity component. For instance, the provision that there are those who will not access care simply because they have not registered, or they do not have the evidence that they are members of this proposed social health insurance. How does that bode with the professional commitments of provision of care, of doing no harm, and beneficence, ensuring in all that you're doing, you're meaning well? And how then does that relate with, for instance, the Bill of Rights in Article, I think, 21 of the Constitution, where then it is the obligation to actually, as an officer, to ensure that you're protecting and upholding this fundamental right to health. whereas you have an act or a provision that seeks to deny that access. So I think that becomes an important bit. But the other bits beyond that, I think the other bit that I think is important for us to reflect on, even as we discuss with these reforms, I think is the aspect of accountability, in the sense that, what lessons are we drawing from people who've gone ahead of us? Let me use an example. Germany is the poster child for social health insurance in its truest of forms. Began in 1883. But in 2018, there are reforms that were proposed in terms of reducing the contributions for the social health insurance. Essentially, because they discovered that the contributions were excluding people from access to care. So if a country that has that wealth of an experience is actually moving away from a mandatory contributory approach, mark you, I'm saying mandatory contributory, not mandatory enrollment, what lessons can we draw from that? Another example, and I know we are learning a lot as a country from Thailand. Thailand in itself had multiple schemes, and one of those schemes was a mandatory or a contributory scheme for the informal sector. What happened is that they had to collapse that post 2002 because they discovered that, one, it wasn't mobilizing enough resources, and it was denying people access to care. So from a provider's perspective and also from a policy perspective, I think it is important that we reflect, particularly at this point in time where we're developing the regulations, and early enough, how do we guarantee equity and access to care, irrespective of whether you can pay or not. A good example also is Rwanda. Of course, Rwanda has a community-based health insurance scheme, as they call it, but the reality is you will notice that there's significant public financing or public sector or public subsidies towards financing of care in Rwanda. But it is noteworthy that in between 2000 and 2011, one of the key things that they struggled with was adequacy of mobilization of resources through the mandatory contributions. And now that is when now the government decided to now pump in a lot more resources towards financing care to ensure that no one is excluded. So to that extent, I think we are at a point where, and I'm happy the drafters and the custodians of this piece of law and these reforms are here. I think it is important to reflect on, one, how do we ensure that we guarantee equity? Because world over, there is significant evidence against contributory mechanisms, and then also reflecting on the reality that then if the Constitution in Article 43 provides that everyone is entitled to the right to health, highest attainable standard of health, and a subsidiary law seeks to exclude them from that by virtue of either having or not having a certain registration, as it were, then doesn't that make the process unconstitutional? And so as you asked in terms of now, how does this impact service provision? I think those are some reflections that we must have in terms of, one, how do we guarantee equity? Knowing that, for instance, if you're looking for the contributory approach, particularly for the social health, you are targeting only 20% of the labor force because we know 80% are in the informal sector. And therefore, accessing them becomes a challenge. And the other conversation around this is, there's a suggestion to use means testing to determine who is able to pay and who is not able to pay. The question is, the resources that you will use to do that, to run the nationwide means testing, how often will you do that? Because I may be able to pay for the insurance today, but who knows what will happen in a year's or in a few months' time. So how often will you be doing this? And how much resources are you going to be using to do this means testing? Would that then be better channeled towards just providing that care? Because anyway, one of the key things we're noticing, whichever way we choose to call these schemes as they are, whether the social health or the community-based successes that we are seeing world over come from schemes that are largely government funded, schemes that then also appreciate the aspect of equity. So those are some of the key things that I think are important. And then also it is important for then the drafters and the policymakers to reflect on what risks do they foresee as far as these new proposals are concerned, and what are they putting in place to ensure that they manage that. And finally, speaking still on accountability, I think it is important to reflect on public will. As has been mentioned, and Thuranira has mentioned this, I think Abdi has mentioned this as well, that we are in a dispensation that perhaps we are seeing more political will. But reforms world over, whereas they are driven by political will, they are also sustained by public will. So to what extent are the critical stakeholders, whether it is the private sector providers, whether it is the counties, whether it is the patients, to what extent have they been involved, and are they being involved in these reforms towards guaranteeing ownership, towards guaranteeing that spirit of public participation, so that then again, it is not just public participation for the sake of doing so, but it is meaningful public participation that actually gets the voice of a stakeholder onto the table. I will stop there for now, and thank you very much.
All right, thank you, Dr. Mulongo. And we are coming to the tail end of the discussion. Thank you, participants. We have over 1,000 participants, and the Q&A box has over 100 questions. So I will try and lump some of the questions together for the panelists to answer. Kindly answer within a minute or less, because I'm just going to pick about on the direct questions. So there's there are many questions on public participation, and many are asking how can they participate, in what forums will they be able to participate, perhaps in the regulations, and also perhaps why. Some are asking why they were not asked to participate before the bills were acts. I think, I don't know which panelists would want to take that up. How public participation is undertaken or has been undertaken in this bill and acts.
Can I?
Yes, sure.
So the law is very clear on the aspect of public participation, and several judgments have been made on the issue of public participation, and several things have failed based on public participation. Now, for the 4 acts of parliament, the phase of public participation ended. And while normally public participation was supposed to be done by the parliamentarians, what we did is that Ministry of Health, being the originator of the bills, conducted their own public participation. The National Assembly conducted their own public participation. Senate conducted their own public participation. So 3 different government entities, or 3 different entities did public participation. What kind of forums? Public participation is like now, we are just discussing the acts and what we expect. A forum, once the court process has been sorted out, we will come to a process like this where we'll come and explain to you people all we have envisioned in the regulations, just for knowledge sake. Then there will be several platforms for you to give feedback. If you look through the advertisement that was put out by the Ministry of Health, it calls for memoranda, individual, organization, groups, or whichever form of memoranda that you come and submit. Public participation can either be virtual, can be physical, or can be through written. You can write or oral submission. So different stakeholders would be called in. We have already mapped all the necessary stakeholders that are there: professional association, unions, employers, employees, patients, patient organizations and such. And letters are written to these people, because before you go present this thing to the committees of health of both houses, you have to, the first question they ask you, did you conduct public participation? And then you have to show them that you made the threshold of public participation. Unfortunately, there is no measure of what is adequate public participation or what is inadequate public participation. what might be adequate public participation to you might not be adequate to me because I was never reached, I was never called out. The same thing we say, different surveys are done by these opinion poll companies, and we disregard the opinion because I was not asked a question. So basically, all the professional associations are written to. I'm sure either most of you belong to a professional association, you belong to a regulator, you belong to a union, and they tend to receive all these kinds of letters, and their representatives tend to come. What you need to do is to channel your comments through them to come and present. Thank you.
All right. Thank you, Dr. Thuranira. There's a question that is quite political. Maybe, I don't know, Dr. Abdi can take this up. How are these UHC acts addressing the issue of corruption? And to tie that in, there was a comment that people have had a very bad experience with the NHIF previously, and perhaps that's why many would oppose anything that looks like NHIF or an insurance. So do you think these acts or bills, the insurances, sort out the issue of corruption in the paper? Dr. Abdi?
Thank you. Not that I'm a politician, that's why you have chosen me, but I will try and answer. There is something that we need to understand, that before NHIF increased the premiums, they used to pay only bed rebates. But after the increment of some of the premiums that they were charging from 320 shilling to 1,700, we have seen increased benefit package that have come on board. So it's not like NHIF was doing zero work. They introduced many things. If you look at in this country today, there will be very few patients who pay cash for dialysis. Most of them use NHIF. Even those who don't have NHIF, once they are diagnosed with kidney failure and they need dialysis, you will find them dashing to NHIF and enrolling. We will discuss that being a bad adverse selection, but it just shows you that there was some benefit. One of the ways that we have tried to reduce that part of NHIF currently as constituted by not taking the same structure to SHA. The reason why we have the many roles separated is to have checks and balances so that you are not the same individual who is registering people, collecting money, and paneling, contracting, deciding the benefit, deciding the rate you want to pay, the tariff, claim processing, paying the claim or not paying, closing, opening. All that was done by one. For the current new body, we have tried to put different entities doing some part of the work so that the individual is not all powerful who is at SHA. They just show up. They take certain instructions from different organizations. One other thing that we have put is a dispute resolution tribunal that will be able to sort out anytime you have an issue. But as you all know, that corruption is not something that you will just end because of the laws or because of the different checks and balances. So it's for all of us to participate. And the other thing that we have done is the transparency bit of it, which is, you know, your benefits, you know the tariffs that's going to be paid, and something that's published. It's not something that someone decides, it's under a table. So that transparency and that checks and balances hopefully will be able to minimize. I will not say it will cut, it will reduce corruption 100%, but it will minimize that power that is concentrated in one individual. So I just wanted to add one more thing Mulongo talked about. Yes, there are many models, even contributory SHI, social health insurance, that are working in many countries. But what we also need to understand is ours is not one model, it's a mixed model. We have tax on one part and we have contribution on another. And even we can even go one more step and do a tax which is earmarked for the critical chronic conditions fund, so that it's also gives us all the three options that we have in terms of financing. So we rather start than agonize on which one is better, which one is not working, which country has succeeded, which one has not succeeded. And UHC, if you really want to do it, I always say start. The same Thailand he's talking about has had different coups. Military guys have come on board and they have never touched the UHC. Why? Because it was started, and once it starts, it develops a life of its own. Thank you.
All right, thank you, Dr. Abdi. People are now bringing in big questions and big paragraphs. I think it would be good to say that we will have another session dissecting this specific act next week. I think the communication will be sent on email or how you got this poster. And some of the questions will actually be answered there. I've seen also questions on community health promoters, primary healthcare, how it will be delivered. There'll be another session on primary healthcare, so look out for that. Then also there are many questions on healthcare workers in terms of what are we doing to ensure we employ more healthcare workers to deliver this UHC. And I think maybe that question may be out of scope for this discussion, but I think going forward, those are questions that we can delve into. A question to Dr. Wangia, just two direct questions. Someone asked, is the 2.75% both to the employer, like the employee paying 2.7 and the employer topping up, or it's one person paying, one entity paying?
So for, as per the regulations, the draft regulations or the posted regulations, it's the employee is the one contributing 2.75%.
So the employer is not contributing to this fund. Okay.
No.
Then another question, why were enhanced schemes removed from this package? You can answer that in the shortest time possible. Enhanced scheme include the civil servant scheme, what the military people had, and many other county governments and all that. Why were they expressly removed from this act?
Yeah, so first of all, NHIF had close to around 96 enhanced schemes, the ones that are just a few. And most of these schemes actually used to eat up into the overall, scheme, especially for the formal sector. So like for the police, they were doing over 100% of their contributions. So at the end of the day, they were basically contributing to, loss making to the fund.
Okay, thank you. I think maybe that question can also be answered in the next session as well. Then there are many questions on the benefits package. How will they be, what benefits people will get, how much will be paid, and there's even an example of why, in the current NHI framework, a surgical procedure in maybe a private hospital in Nairobi would cost 80,000. But when the patient goes to a public hospital, the public hospital is not reimbursed the same amount of money. And I think some of these questions around benefits package and how empaneling will be done for hospitals. And there are also questions on the claims management process. I think some of them have been answered in the regulations that have been published. So I would encourage all of us to look out for when the public participation will happen. And as Dr. Thuranira has said, let us channel our public participation through our associations, our unions, or even hospitals, or even as an individual. But again, we will have another session to delve further into that. And I think that there are so many questions on the benefits package, people asking how ICUs will be reimbursed in private hospitals or higher tier hospitals. in private hospitals, and level 4, level 5, and level 6 hospitals. So I think those discussions, we may not be able to delve further into that. And from the Q&A, I think there are some questions we've answered throughout the discussion, where someone asked, I work for an NGO, I pay NHIF, but I get covered by a private insurance. Kindly explain how this works. I think that has been sorted in the discussion. Yeah, and there are some panelists who had indicated they would like to answer some of the questions online. So the floor is open. Dr. Mulongo, you can have a comment and answer a question in 1 minute. We should end this in the next 5 minutes. Dr. Mulongo?
Oh, okay. Thank you, Abdi, for the comment. And yeah, I think the point is, how do we learn and how do we draw lessons from those who've already gone ahead of us? And how do we then also minimize flaws as we continue along the journey of universal health coverage? I think the other bit that I think, and as perhaps we'll explore this in part 2, is just delving into the nitty-gritties of the individual acts, particularly the Social Health Insurance Act. I think the conversation on separation of roles is an interesting one, but the drafting as is speaks to particularly Article 35 of the Social Health Insurance Act of 2023, speaks to the establishment of a claims management office within the authority. So then it will be, we will explore that, I think, with Abdi and Dr. Wangia in the next session, as to how that is essentially separation of roles, whereas that still is domiciled within the authority. That's number one. Number two, and the safeguards or the governance and accountability measures in place to just guarantee that the public will draw value from the roles that are the different offices that are being created within the current act. Suffice to note, I think let's leverage and think on sustainability. Let's think on equity. Let's think particularly within our context and the reality of the resources that we have, and how and the challenges that we currently face, as it were, and particularly how do we guarantee public ownership as we journey this journey of the universal health coverage. Over, and thank you.
All right, thank you, Dr. Mulongo. We'll give each panelist 1 minute to give their final remark. You could choose to answer a question that you saw in the chat box, or just give a final remark. But I think towards the tail end, we would want to know what does the future look like. Dr. Wangia?
What does the future look like? Yeah, so
Yes.
I believe anytime we are looking at universal health coverage in general, we want to look at expansion of the services as you expand you expand the service for the expanded population. So in the future, with streamlined systems, we should be able to get more help out of the money that we'll invest, and therefore be able to constantly increase the package, or the services covered within the package. That's the future that I'm seeing.
Okay. Dr. Abdi? Thank you.
Thank
Dr.
you. I think there's one thing that I have seen from a data in terms of when dialysis was introduced in 2017 by NHIF. We had around 260 renal nurses. By 2022, we had 600 renal nurses in the country. So what does that tell you? It tells you that once you address the financing mechanism for any healthcare, then in terms of numbers of personnel will always increase. One of the reasons why there are drops of people going to the West is because they managed to address their healthcare financing. and so the demand for healthcare workers will increase because there's no way you will be able to provide services if you don't have the human resource. So you will have to, even if you are a county, you will have to now employ because you only get reimbursed or paid for if you have people who are able to deliver that service. So for me, addressing the financing mechanism will automatically, in one way or another, will be able to address the human resource aspect because they go hand in hand. So for me, I see an opportunity to start because we can analyze these things 1,001 times. We can be skeptical. We can have transparency issues. We can have willingness to pay. We know we have a large informal sector, almost 80%. All those things are known, but you can only be able to move ahead is if you start the journey. Then be able and open-minded to adjust as you go along. And I think that is one thing that I would applaud the current government on in terms of listening, trying to understand what are the inputs or what is it that you think is a better idea than what's being proposed. So we just need to engage rather than be outside and complain. So let this journey not also leave us the same way when the constitution was being made, that train left us. We have an opportunity to shape our destiny currently in whichever way we would like to see these things happening. And we need just to put ideas and ways of doing things or how we would like things to be done.
Okay.
That's my input. Thank you very much.
Dr. Mlongo, 30 seconds.
Thank you. 30 seconds. One, it's a journey, and therefore we are starting from somewhere. So let's appreciate the lessons and the lessons drawn from the past and the reforms that have been there, so that then we don't end up in the hitches that may have been experienced in the past, but appreciating that it is a progressive journey in terms of who is covered, what services are covered, what costs are covered. That's number one. Number two, in this journey, for us to ensure that then we remain relevant, it is important to remain inclusive and to remain open to learnings from within, learnings from outsiders, learning from our peers and those that are even higher, so that then we're able to have a very contextual journey, as it were. Three, and I think this for me would be the most critical one, is equity. As we enforce these reforms, how do we ensure that the very spirit of universal health coverage, of not leaving anyone behind, is upheld, appreciating that we live in a context where there are those who are on the fringes, either geographically, by income, by gender, by a spiritual, religious affiliation, or whatever kind that may be. So I think for me, the biggest block here would be how do we journey this UHC journey with equity in mind, even in the reforms as we make them. Thank you very much. Over.
All right. Dr. Thuranira? Your last comment.
If he is not around, I saw he dropped. I can add just one thing. The current contribution of NHIF has been the most unequal one. If you look at in terms of percentage of what people pay. So in the new scheme, we have moved to a rate that makes it more equitable. In the current system, we have different schemes with different benefits, some of them paying almost similar amounts or not, but some getting more benefits than the others. With the new scheme, the benefits and the tariffs are all equal, so that you don't have any sort of inequity. So I think those two we have tried in terms of making it equitable. But if there are better ways of making it even more equitable, that is a discussion that's open. Thank you very much.
All right. Thank you all the panelists for participating in our discussions. Participants, most importantly, thank you. We had about 1,200 participants on the call, and as at now we are at 800. We really appreciate your time. For the many of you who put your questions in the chat box, some of them panelists were able to answer. Some of them, they were answered in the discussion, and some may not have been answered. We really apologize that we could not perhaps keep this discussion longer to answer all the questions, but the panelists and perhaps the government is listening to all the diverse opinions put in the chat box, and I think our opinions can be taken into account. Housekeeping issues, CPD points will be provided by your respective professional bodies. That was sent on email. The recording will also be on YouTube, so some asked to be emailed. So there's a YouTube page called the KNH UN webinar. The recording will be there, and we'll also try and put it on the KMA. Kenya Medical Association also has a YouTube page. We'll also put the recording there. We would like to thank everyone for participating. From our panelists for taking your time. Some of you are on the road taking time in the evening. You should be home with your families. And also participants, we really appreciate all of you for taking the time to participate in this webinar. A reminder, this is a series. The discussion starts today, but it doesn't end today. We'll have at least 4 more sessions. One will be to dissect the acts individually, including the social health insurance. I feel like for this social health insurance, we probably need a whole day for everyone to dissect. And perhaps a word of encouragement to everyone that in as much as maybe all our diverse opinions may not be reflected in the act, I think we also have to appreciate that the teams that are working on these regulations and the work put in is for the benefit of many Kenyans. KMA also appreciates that we are here to support doctors and also other professionals. So should you have any questions or comments regarding this topic, you can channel it to us. And I think what the message as we close the evening is that UHC is not a destination. Perhaps we will not arrive in 2024 June and say we have achieved UHC, or perhaps in 2027, but it's a journey towards starting. And I like what Dr. Abdi said. It's a journey which we have started, and it can evolve and have a life of its own. And we hope that we'll be able to raise the resources to improve quality healthcare in this country. Thank you, everyone. Have a good night. See you next week.